Chairpersons, colleagues and friends. The ECG I divided into two sessions. First, I will tell something about the role of ECG in acute coronary syndrome, and then there will be something like a quiz program, which is meant for the postgraduate students. Can the postgraduate students raise their hands? Electrocardiogram is the most useful investigation in patients with chest pain for diagnosis, evaluation, and guidance to therapy. ECG is useful to diagnose STEMI, locate the site of infarction and artery involved, decide the extent of infarct, recognize and diagnose complications, assess the benefit of reperfusion therapy. The ECG changes during acute phase of STEMI are three phases. The first one, the T wave becomes tall, symmetrical, and peaked. Grade 1 change. Grade 2 change, that is the second change, there is ST elevation with concavity upwards without QRS distortion. Third, changes in the QRS complex, which is grade 3 change where there is QRS distortion. The QRS distortion is best manifested in leads where there is an R, small r with deepest pattern. So here is a initial ECG where there is an R wave and S wave, which is gradually getting distorted and finally becomes a tall R wave. That is the QRS distortion. That is a final third grade of the ECG change. This is an electrocardiogram where all the three changes are seen. This is the grade 1 change where you can see very tall peak T waves. There is minor reduction in the R wave, but the QRS duration remains the same. And this is the grade 2 change where you can actually see the ST segment is elevated and it is concave upwards, but the QRS morphology is still correct. And the third one where there is a QRS distortion where the smaller R deepest pattern has been replaced by an R wave. This is the third stage of the electrocardiographic abnormality in acute coronary syndrome, especially ST elevation myocardial infarction. In a 12-lead electrocardiogram, presence of indicative and reciprocal changes confirms STEMI in 95% of cases. It's extremely important. Most of us mostly look for only indicative changes. The indicative changes are the changes which are seen on the leads facing the area of infarct, and usually it is ST segment elevation. The reciprocal changes are the changes seen in leads away from the area of infarction, and these are mostly ST segment depression. And if an electrocardiogram shows both ST segment elevation as well as the reciprocal change, almost 95% it is due to an ischemic event, acute myocardial infarction. But if there is only an indicative change, that ST segment elevation only, and no reciprocal change, it could be other conditions like myocarditis, it could be Takotsubo cardiomyopathy. There are other conditions where there can be an ST segment elevation. So always look for a reciprocal change, which is ST segment depression seen in an opposite lead. Now let's look at a few ECGs in non-ST elevation acute coronary syndrome. So here is an electrocardiogram. You can see that there are few abnormalities which indicate that the patient is already a high-risk candidate. This has been well elucidated by a previous speaker, Bino, in his talk, where you can see that there is an elevation of the ST segment elevation in AVR and ST segment elevation in V1 and significant ST depression in chest leads. If the ST elevation is more in AVR than in V1, there is a suggestion that more likely the left main is involved. And if there is an ST elevation more in V1 than in AVR, it may indicate that the involvement may be proximal LAD. Now let us look at how to localize infarction and the artery involved. Anterior myocardial infarction. Now this is there are 4 sites of involvement of the left anterior descending artery. First site is here, which is proximal to all its branches. no, before the septal branch, before the diagonal. Next one is, you can see that this is the beyond the diagonal, this is the diagonal, but before the septal. So this is beyond the diagonal, before the septal. Third one is beyond the septal, but before the diagonal. And fourth one is beyond both septal as well as diagonal. So by looking at the surface electrocardiogram, can we make out where is the occlusion? Is it proximal, or is it beyond the S1, or is it beyond D1, or is it beyond both? So there are simple clues by which we can diagnose it. These are 4 electrocardiograms. And are there any volunteers from the electrocardiogram to tell whether the first one, where is the occlusion? Is it proximal to S1, proximal to D1, or is it distal to one of the arteries or distal to both the arteries? Are there any DM students here from Trichur Medical College? Or from Jubilee Mission? Or from Amala Hospital? Okay. MD students, you are doing DM. Would you like to try? What is the first one showing? I will give you a clue. You just look at only AVR and AVL. If the AVR and AVL both shows ST segment elevation, it is proximal to S1 and D1. If there is a ST segment elevation in AVR and not in AVL, it indicates that the occlusion is proximal to the S1 but maybe distal to D1. If there is AVL elevation, ST elevation, but there is no ST elevation in AVR, it indicates that occlusion is proximal to D1 and distal to S1. If both S1 and both AVR and AVL are not showing any ST segment elevation, then you can conclude that it is distal to both S1 and D1. So if you look at here, this patient is having ST segment elevation in AVL. Is it clear? Is there ST segment elevation in AVR? It's clear? And so, where is the occlusion? It is proximal to S1 and D1. And there are some additional points that you can look at. And these patients usually will have ST segment depression in V5 and V6. It usually indicates an extensive myocardial ischemia. Second, let's look at here. Any takers? You can try now. What does that AVR show? Maybe minimal elevation, not very striking. AVL does not show any elevation. But if there is no AVR ST elevation, you must always look at V1 also. V1 and AVR go together. If the V1 also is showing ST elevation, that can be considered that it is proximal to the S1. So here, the AVR ST elevation is very minimal, but you can see good ST elevation in V1, but there is no ST elevation in AVL. So it is distal to, the occlusion is distal to D1, because AVL is not showing any ST elevation. But it is proximal to S1 because there is ST elevation in V1. So this electrocardiogram shows that the occlusion is proximal to S1 but distal to D1. Let us look at here. What does it show? Let us look at the two leads that I looked at. AVL. AVL shows ST elevation. AVR, no ST elevation. V1, no ST elevation. So this is, where is the location? The D1 is involved, so it is proximal to D1 but distal to S1. And finally the last one, where there is no ST elevation in AVR, no ST elevation in AVL, no ST elevation in V1, but you can see ST elevation in 2, 3 and inferior leads, and this usually indicates that the occlusion is distal to D1 and S1. So by looking at two leads, you can make out whether the occlusion is proximal to S1, D1. You can make out whether it is distal to S1 and proximal to D1. You can make out whether distal to D1, proximal to S1, or distal to both D1 and S1 without any difficulty. And by electrocardiogram, it has been shown that ST elevation in AVR, the sensitivity is 43%, specificity 95% for proximal LAD occlusion. Right bundle branch block, another indication for LAD proximal occlusion. ST depression in V5, proximal LAD occlusion, and ST elevation in V1 more than 2.5 millimeters. All these points indicate that there is a proximal LAD occlusion, or it could be even a left main occlusion, and it indicates severe extensive ischemia. Now let us look at the inferior wall ST elevation, myocardial infarction. Here you can see that there is a, which is the leads which are showing maximum ST elevation. You can see that there is ST elevation here, but there is a significant ST elevation in V1, V2 and V3. Also in V4. And you can see significant ST elevation in V3R and V4R. So these leads indicate RV infarction. So when we are looking at an ST elevation in V1, V2, V3, V4, you may confuse whether it is an anterior wall myocardial infarction. How to differentiate? The differentiation is, you must look at what is the pattern of ST elevation. In anterior myocardial infarction, ST elevation will go on increasing from V1 to V2 to V3 to V4. It will progressively increase. While in RV infarction, it will decrease from V1 to V2 to V3 to V4. So if the ST elevation is decreasing from V1 to V4, it is an RV infarction reflected, and if it is increasing from V1 to V4, it is an anterior wall myocardial infarction. So this patient has got inferior wall myocardial infarction. There is a ST elevation lead 2, lead 3, and also in AVF. The patient has got reciprocal changes, ST depression in AVL, and on top of that, there is evidence of ST elevation in V1, which is more than in V2, which is more than in V3, which is more than in V4. And you can see significant ST elevation in V3R and V4R. So this patient has got a proximal RC occlusion. In proximal RC occlusion, you can see significant ST elevation in leads V3R, V4R, V1, V2, V3. And this is a proximal RC occlusion. There is another example of inferior myocardial infarction. You can see that there is a ST elevation in lead 1, lead 2, lead 3, and AVF. The reciprocal changes are also seen. And you can see some, again, you can see there is some ST elevation in V4R. And probably there is some ST depression in V1, V2, V3, indicating that areas involved are inferior wall, right ventricle, maybe slightly distal part, the elevation is not gross, and there is some ST depression in V2, V3, indicating that probably the ischemia is extending to the posterior wall. So it is inferior wall plus right ventricle, and also maybe extending into the posterior wall. Here is an example of a patient with inferior myocardial infarction. You can see the lead 2, lead 3, and AVF showing ST elevation. Lead 1 and AVL showing reciprocal changes. And there are ST depressions in NHS leads. And you can see that there is ST elevation in V7 and V8, indicating posterior wall myocardial infarction. So this patient has got inferior wall and definitely posterior wall myocardial infarction. The reciprocal ST depression may be a reflection of the posterior wall myocardial infarction. And this type of an electrocardiogram can be either due to a circumflex artery involvement or maybe in a large RCA also. So this type of patients with posterior wall myocardial infarction, you must always think about the possibility of a circumflex artery involvement. It also is another inferior myocardial infarction. So we'll go to the next slide. Sometimes you may have difficulty in diagnosing acute myocardial infarction in a patient who has got a pre-existing left bundle branch block. So there are criteria has been put forward for that. The three criteria are ST segment elevation of equal to or more than 1 millimeter and concordant with QRS complex in V5 and V6, 5 points. ST segment depression more than 1 millimeter equal to or more than 1 millimeter in leads V1, V2 or V3, score 3 points. ST segment elevation of equal to or more than 5 millimeters and discordant with QRS complex, score 2 points. And a score of 3 indicate myocardial infarction. So let us look at an example. Here is a patient with left bundle branch block. You can see ST segment elevation in V6. You can see ST segment elevation in V5. And also you can see some ST depression in V1. ST elevation also is in V2, V3. All indicate that this patient has got associated acute ST elevation myocardial infarction. So in presence of pre-existing left bundle branch block, sometimes the acute myocardial infarction changes may be partly may not be brought out in the electrocardiogram because the left bundle branch block itself can give rise to some STT changes. So if these changes are there, where there is ST elevation is seen in V5 and V6, some ST depression in V2, V1, V2, V3. Here you can see ST depression in V1. And if there is an ST elevation in V2 and V3, all those are points, ST depression in V2 and V3, all are points for you to suspect that patient may be having associated acute ST elevation myocardial infarction. Now the complications of acute myocardial infarction can be easily picked up by electrocardiogram. Here is an example of a patient with previous myocardial infarction. He has got a trifascicular block. What is meant by trifascicular block? Any one of you? Trifascicular block means we have got three fascicles. One is the right bundle branch, another is the left anterior fascicle, and the left posterior fascicle. If all the three fascicles are involved, then it is known as a trifascicular block. So here you can see the patient is having right bundle branch block. The patient has got left axis deviation indicating that patient is having a left anterior fascicular block, and the first degree heart block, which indicates that probably the posterior fascicle also is involved. So this patient is having a trifascicular block. And if you look at carefully, this patient is having Q waves in V1, there is a rudimentary R in V2, the rudimentary R in V3, there's probably Q wave in, not probably, there is a Q wave in V5, and this also is very rudimentary R wave, all indicating that patient had a previous myocardial infarction as evidenced by Q waves in the chest leads. So he has got previous myocardial infarction and a trifascicular block. Another ECG takers. Any takers? This ECG shows, if you are careful here, you can see the alternating left bundle branch block and right bundle branch block. This is V1. This alternating left bundle, right bundle, left bundle, right bundle. So alternating left bundle and right bundle branch block. And you can see ST segment elevation indicating that the patient had acute myocardial infarction and alternating left and right bundle branch block. And this also is a trifascicular block. And for DM students, if there are any DM students, this is alternating right bundle branch, left bundle branch block with acute anterior myocardial infarction. And there are a number of electrocardiographic situations where you can diagnose trifascicular block from the surface electrocardiogram. I have enumerated 9 of them. If there are any DM students, probably for MD students, this question may not be asked. But if there are DM students, definitely you can look at it. Go through that. Okay. I think I will go to the pseudo-infarction patterns. This is very important. Pseudo-infarction patterns. There can be electrocardiographic abnormality which may indicate that the patient may be having an infarction, but actually it is a pseudo-infarction pattern. Here is a patient who has got ST elevation everywhere. I told you in my beginning lecture that when there is only ST elevation, indicative change, you are right in making a diagnosis of acute myocardial infarction, 55%. You have to get reciprocal changes also. When you get reciprocal changes also, the correct diagnosis is almost 95%. This patient has extensive ST elevation in all leads with no reciprocal changes. And we did a coronary angiogram, the patient had normal coronaries. So you have to think of conditions other than ischemic myocardial injury. It could be an infection like myocarditis, or it may be a stress cardiomyopathy. So if there is an extensive ST elevation without reciprocal change, that may tell you that the patient may be having something different from acute myocardial infarction. Here is a patient with Q waves in lead 2, lead 3 and AVF, and then there is an R wave in V1 which may tell you that patient had a previous myocardial infarction. But this, if you are very careful, you can see that it is a WPW syndrome, where you can see that there is a short PR interval, there is a delta wave, and a broadening of the QRS complex. All indicate that the patient is having a WPW syndrome. There is a situation where there is ST segment elevation all over. You can see ST segment elevation will lead to everywhere and with no distortion of the QRS complex. So when there is no distortion of the QRS complex, you are seeing only ST segment elevation, no reciprocal changes. Always think of the possibility different from the acute myocardial infarction, and this was a patient with acute pericarditis. So pericarditis patients can have widespread ST segment elevation. They can have ST depression in AVR, and the QRS will not be distorted. Here is a situation where you are seeing an ST elevation in V1, V2 and V3. This is another situation where you can see ST elevation in V1, V2, not in V3, you can see in V1 and V2. Here also is another patient with ST elevation in V1, V2, to some extent in V3. So whenever you are having an ST elevation in V1, V2, V3, a possibility of Brugada syndrome should be considered. So patients with Brugada syndrome is a channelopathy where the patients can develop ventricular arrhythmias, and there can be sudden cardiac death, and they have ST elevation in V1, V2 and V3. So when it is restricted to V1, V2, V3, and you always think of a possibility of a Brugada syndrome. And here is a patient with ST elevation in multiple leads and with normal QRS, relative bradycardia, and this is a situation where there is something known as early repolarization abnormality. Here is an example of a patient who came to me because he was referred because of the electrocardiographic change. He had no chest pain, but routine electrocardiogram showed deep T-wave inversion from lead 1, lead 2, everywhere. All over the chest leads, V2, V3, V4, V3, V4, V5, V6. And also there is evidence of left ventricular hypertrophy. What could be the diagnosis? DM student? Which one? It is apical hypertrophic cardiomyopathy. It is an apical hypertrophic cardiomyopathy. You get this type of symmetrical T-wave inversion with tall R waves indicating left ventricular hypertrophy, and that should be your diagnosis. This apical hypertrophic cardiomyopathy. Sometimes you may find Q waves in the electrocardiogram. One interesting feature here is that this patient has got Q waves, and in leads with Q waves there is no T-wave inversion. But in leads without Q waves, you can see T-wave inversion. So you can see, no, Q waves are seen in lead 1, Q waves are seen in AVL, Q waves are seen in these two leads, and shows the T is not inverted. While you can see T-wave inversion in lead 3 and AVF where there are no Q waves. And you look at the chest leads, you can see plenty of Q waves with upright T-wave. So here is an abnormal situation where the patient is having Q waves. Where there is a Q wave, that lead shows T-wave normal. And in leads where there is no Q wave, you have got T-wave inversion. When you see this combination, you must always think of a possibility of not a myocardial infarction, but it could be a hypertrophic obstructive cardiomyopathy, especially septal hypertrophy. So whenever you see this type of an abnormal electrocardiogram, think about the possibility of hypertrophic obstructive cardiomyopathy. Sometimes hyperkalemia is a big masquerader. You can see multiple electrocardiographic abnormalities in hyperkalemia. This is an example of an hyperkalemia. You can see tall T waves. You can see some rhythm abnormality. It's another example of hyperkalemia. You can see tall peak T waves, some ECG abnormalities. And this is a third example where you can see sine wave pattern, where there is gross QRS distortion, absent ST segment. All these abnormalities point towards the hyperkalemia. So whenever you see a grossly abnormal electrocardiogram which does not fit in with any regular electrocardiographic abnormality, always think of the possibility of hyperkalemia. Now there is a quiz program. If you don't answer, I think we will stop at that level. So I am going to show you arrhythmias. Anybody can try? What is this arrhythmia? Simple. This is very simple. This is a tachycardia, narrow QRS complex. Rate is around 200. So the diagnosis is supraventricular tachycardia. What variety? Is it AV nodal reentry tachycardia or is it AV reentry tachycardia? When the P waves are not seen at all, most likely it is submerged inside the QRS complex. That will be most likely it is an AV nodal reentry tachycardia. So here you are not able to see the P wave. So this is an AV nodal reentry tachycardia. Now let's look at the second one. What is this? Here also is a narrow QRS complex. The rate is around 160, 170. But here you can see the P waves. If you are very careful, you can see the P waves here. A small notch is seen. Can you see a notch here? My pointer indicates the notch. In lead 2, you can see a notch here. It is just outside the QRS complex. When there is a small notch just outside the QRS complex, it usually indicates that it is most likely AV reentry tachycardia. There is an X-ray pathway and there is an AV reentry tachycardia. The first one is an AV nodal reentry tachycardia. The second one is an AV reentry tachycardia. Takers. What does the electrocardiogram show? What is the arrhythmia? Yes, atrial flutter. The patient is having an atrial flutter. Of course, he has got associated anterior myocardial infarction, but the arrhythmia is atrial flutter. Very good. Diagnosis. This is a broad QRS complex tachycardia. Default diagnosis. The default diagnosis of a broad QRS complex tachycardia is ventricular tachycardia. Very good. This is a ventricular tachycardia. I am not spending much time on that. This also is ventricular tachycardia. What is this? Little more difficult. I can't hear you. Is it regular or irregular? It is irregular. And it is irregularly irregular. Commonest cause of irregular rhythm is atrial fibrillation. But then the patient is having a variety of QRS morphology. Broad, narrow, intermediate. What is the basic situation where in a patient with atrial fibrillation you can have this type of a morphology associated with WPW. So this is a patient with WPW. Just one more minute. When I have finished, you just tell me, I can stop. And I can continue for any length of time. So as soon as so when it is time, you just let me know, I will stop. Okay, so this is because I have brought about 70 electrocardiograms, so does not matter. This is a WPW syndrome with atrial fibrillation. Very simple. This is a polymorphic ventricular tachycardia and goes by the name torsade de pointis. This is a polymorphic ventricular tachycardia. Diagnosis. What do you find here? The P wave is marching in and out of the QRS complex. It's going inside the QRS complex, going inside the QRS complex, getting out of the QRS complex. So it's marching in and outside the QRS complex. It is said that the P wave is flirting with the QRS complex. Flirting, all of you know. So it is flirting with the QRS complex. What is the diagnosis? DM student? What is the diagnosis? This is known as isorhythmic AV dissociation. Isorhythmic AV dissociation, where the P wave marches into the QRS complex, goes beyond and gets out. Oh, this is a very interesting ECG diagnosis. This is a very unusual arrhythmia, not a common one. What do you find here? You can see the QRS complex, suddenly it has disappeared. And in between you can continue to see P waves here. So what is that situation where the patient is having a regular rhythm and suddenly the P wave does not conduct and does not produce QRS complex? There is an AV conduction abnormality. Is it Mobitz type 1 Wengeback phenomenon? Or is it something else? It's a Mobitz type 2 block. Patient is having a morbid type 2 block where a large number of PVs are not conducted, and these patients are candidates for permanent pacemaker implantation because they can fall dead because the PVA may not get conducted and the whole thing can suddenly stop and the patient can fall dead. So this is an indication for permanent pacemaker implantation. Morbid type 2 arrhythmia is extremely rare. We are fortunate enough to have a electrocardiogram in a Holter monitoring, and that is why I could show you that. This is a very rare arrhythmia. Of all arrhythmias, this is only about 1%. So that is why it is extremely rare. Diagnosis. Okay, the time is up. Thank you so much, and thank you so much for the opportunity. Thank you.
I think the wonderful collection of ECGs you have. I think if this is made into a small booklet or something, or a pen drive, if the organizers can supply to the physicians attending this, they will benefit. Because all are typical changes, ECGs you have presented. Congratulations.
Thank you.
Actually, we are planning to have all these presentations in a YouTube channel. We'll start a YouTube channel and we'll upload all these presentations on the YouTube channel. So then everyone will be benefited. They can refer it in a later time. So all this will be uploaded, and everyone who has registered will give the details later.
I hope students could at least understand some of the electrocardiograms and also how to evaluate the extent of infarction by looking at the anterior myocardial infarction, inferior myocardial infarction. You must always try to interpret it. Then only you should put it to practice. Then only it becomes easy for you. If you don't practice it, it will never come. It will be always difficult for you. Once you do it, it becomes easy. Thank you. Thank you for the organizers.
Okay. Thank you.